Hello, everybody, and welcome to the PCR Tricuspid Focus Group webinar called The Journey Through Tricuspid Regurgitation Phenotypes. It's really my pleasure to share with you some new information. What you will get in this webinar is the following. We will really focus on two important new phenotypes where we are working together with a multidisciplinary team to define indications and management of patients with atherogenic secondary TR and with patients with CIED-related TR. We will discuss about the current outcomes of TEER and other technologies, even including surgery in patients with atrial secondary TR and what to do in patients with CIED-related TR where surgical endovascular management comes into play. So without further delay, I want to introduce my team today. We are very pleased to have Martin Andreas from Vienna and Denisa Muraro from Milano. They both have been first authors of very important papers on atrial STR and on CIED-related TR. And also we have Mariana Adamo from Brescia and Christoph Stark, who are the two experts of interventions for TR-related, atherogenic TR and for CIED-related TR. So without further delay, I would like to introduce the first speaker, who is going to be Denisa Muraro, who will cover the topic of atherogenic secondary TR.
Hello, everyone, and thank you very much for the kind invitation. It's a great pleasure to be part of this fantastic webinar with such a great team. So in the following presentation, the point is to summarize the key messages of this recent consensus document that has been published in European Heart Journal by the PCR Tricuspid Focus Group. And indeed, we have aimed to provide and to focus on this new entity, which is called atrial secondary TR, because it is quite peculiar with respect to the more prevalent ventricular type of secondary TR. And also another reason is that atrial fibrillation is so prevalent. So we see a lot of these patients, particularly elderly women, either with atrial fibrillation or with HFpEF in sinus rhythm, that present with right-sided heart failure signs. And with imaging, we find peculiar characteristics. Usually they have very enlarged right atrium, but they have normal ventricles with normal LV and RV function, and they do not have other cause of tricuspid regurgitation. So it seems that in these patients with long-standing atrial fibrillation, the main trigger for the dilation of the annulus is the dysfunction and the dilation of the right atrium that leads to an imbalance between the leaflets and the area of the annulus. However, an important key message of the paper is that atrial fibrillation is not mandatory for the diagnosis of atrial secondary TR. Indeed, there are many data suggesting there are some elderly that do not have documented atrial fibrillation but present all the other characteristics. And it is not clear why these patients have right atrial dilation, but it seems that can be explained by a right atrial myopathy, and they can present with some mild increase in pulmonary pressures and diastolic dysfunction. So the phenotype from an imaging point of view is completely different from the ventricular secondary TR. First of all, in the more common ventricular form, the ventricle is more spherical, is enlarged and dysfunctional, and there is a tethering of the leaflets, while in the atrial secondary TR, there is usually no tethering, or the tethering is trivial, and we just have a triangular shaped right ventricle. If you look at both of these examples, the right atrium is dilated in both, but what is characteristic is to look at the ratio between the right atrium and the right ventricle at end systole. And when this exceeds 1.5, so the right atrium is disproportionate with respect to the right ventricle, this is typical for atrial secondary TR. So this is just to summarize some of the main characteristic features of both phenotypes. First of all, I already said that RV dysfunction is typical for ventricular secondary TR, as well as a significant degree of pulmonary hypertension, or this patient may have significant left-sided disease. On the other hand, atrial secondary TR does not have any other cause for TR except the dilation of the annulus and the right atrium. Many studies have shown that these patients, both as a natural history, but also with treatment, they have a better survival, a better prognosis, much better than those patients with pulmonary hypertension, justifying the fact that we should concentrate on identifying them and treating them early in their natural course. So these are some of the reasons why in this document recently published by the PCR Tricuspid Focus Group, it has been proposed to subclassify the patients with secondary TR and distinguish atrial from the ventricular form due to their distinct phenotype and also due to their better outcome. However, when we apply these in clinical practice, we face some difficulties because there are also some overlapping features that are explained in the paper. Most of these are the fact that the right atrium is dilated in both, but they both can have atrial fibrillation. They both can have some degree of pulmonary hypertension. So we need to have a very systematic approach, including careful clinical history, expert imaging protocol, and right heart catheterization to understand and to try to distinguish between the two. Many times, if these patients present in late phase, it will not be possible and they can be labeled as mixed disease. An important key message to recall is the fact that these patients are prone to be underestimated, underdiagnosed, and undertreated because it is challenging to evaluate TR in patients with atrial fibrillation, especially if they are old, and also some symptoms can be neglected. So there are many reasons why with a normal echocardiography, the degree of TR can be underdiagnosed. So this underlines the fact that these patients should be referred to expert centers that are specialized in imaging the tricuspid valve and tricuspid regurgitation. So to summarize, these would be the main diagnostic criteria. We have 6 criteria, and there will be also a table summarizing the cutoff values that we are proposing in order to distinguish the two phenotypes. For the sake of time, I will not go into it. You can find that in the paper. So just briefly, a very typical clinical case, an elderly woman, 80-year-old with persistent AF in the past 3 months, presenting with shortness of breath. She has a really severe tricuspid regurgitation with an elliptical orifice and a 3D vena contracta of 1 centimeter square. And we have managed to restore the sinus rhythm successfully. And this is the result after 3 months. You see that the tricuspid regurgitation has been reduced from massive to a moderate degree. And this is an important aspect. Since atrial fibrillation is the cause of the TR, we should treat it as aggressively as possible. So regarding the management of these patients, as I said, we need to target the underlying disease process and not just address symptomatic treatment with diuretics. We should consider, even in patients with mild TR, if they are having atrial fibrillation and they have risk markers of TR progression, these should be more carefully evaluated and followed with both clinical and echocardiography. The first step should be rhythm control, especially if the atrial fibrillation has not been long enough. And finally, these patients should be evaluated and treated also for heart failure with preserved ejection fraction. And finally, it is key to have a multidisciplinary heart team, including electrophysiologists and heart failure specialists, to try to treat AF and slow TR progression. And this is key also to decide the right timing of the intervention. Thank you very much for the kind attention.
Thank you, Denisa. And I want to again congratulate you and all the authors who have been putting together this paper, which is probably the first one that tries to help us to differentiate between this new etiology somehow has been described many years ago, but only 5 years ago came to our attention. And so it is a very important aspect of tricuspid regurgitation. So you just mentioned the role of the multidisciplinary team. And I would like to engage Marianna Adamo, who has been working on a similar paper, again, from the tricuspid focus group on how to manage patients with heart failure and tricuspid regurgitation. So we are talking about the heart failure team, or let's say the tricuspid regurgitation team. What is it about it? Marianna, tell us what is your opinion. And in the meanwhile, I also would like to encourage anyone who wants to interact with us. There is a chat line, and Denisa is ready to interact with the audience. So whoever wants to ask you questions, please ask questions through the chat, and we will try to answer. So Marianna, we're talking about multidisciplinary team, what that means in real practice here.
Yes, thanks, Francesco, for the question. Thanks for the invitation. Yes, the role of the heart failure specialist is crucial in this kind of patients, because the prevalence of tricuspid regurgitation is really high in both patients with FPF and FREF. So we see a lot of these patients in our ambulatory setting, especially, but also in our during the hospitalization. But most of these patients, especially those with atrial TR, are not hospitalized, so they are outpatients. The role of heart failure specialists is important, but the team includes also clinical cardiologists and general practitioners, because these patients are often referred to general practitioners for peripheral edema or specific symptoms. So if we want to identify these patients earlier, we have to increase awareness of the disease, and we have to work together with all these figures, and we have to try to capture these patients at an earlier stage. We identified some red flags in our paper, position paper of the Heart Failure Association, to identify earlier these patients, and atrial fibrillation and FPF are the two key elements to be looked for to identify patients with TR.
So Marianna, we have also two surgeons in this webinar, so I want to involve, maybe I will involve Martin Andreas now. What is the role of surgery in the heart team for tricuspid? Is surgery still an option for these patients? So, for instance, this patient, 80-year-old lady with atherogenic TR, and she had a very good response with rhythm management. Imagine she remains symptomatic and she requires an intervention. So, is age a problem for surgery? What is how to approach these patients?
So, Francesco, thank you for your question, and hello to everybody. So I think most importantly, we have to acknowledge that tricuspid disease, especially isolated tricuspid disease, does have an increased risk, which is not directly reflected by the Euroscore. So we have to calculate specific risk scores for these patients, like the CRS score, the MELD score, or the TRI-score, and really discuss these patients in the heart team. I think age is a problem, and we do have nowadays very good interventional alternatives, but for patients who have atherogenic tricuspid regurg, still annuloplasty is the best option to treat this.
Okay, very good. And I want to come back to Denisa, because Denisa, you are really an expert in the field, and you have been discussing about the mechanics of atherogenic TR. But also, I'd like to ask you one thing. So I have the impression that the torrential TR usually is not seen in these patients. They usually have more reasonable amount of regurgitation. Now, the question to me is the following. Now, you have shown us a patient where TR was reduced to moderate. Now, the question is mild to moderate or moderate to severe. So we know that you are the one who is really raising the awareness about the role of moderate TR in the prognosis. So what is your feeling? Would you be happy just to go from severe to moderate, or you want to get less?
Yeah, excellent question. Of course, any reduction is important, but moderate should not be reassuring, because we know very well that these patients are also at adverse outcome. So, but however, a reduction from massive to moderate may delay, the interventional treatment, and so we can prolong, the disease course of these patients. Many times it's not possible to have a significant reduction because the problem remains, so they still have dilation of the annulus and they might have recurrence of atrial fibrillation. But the point is to delay the moment in which these patients need to be treated, if possible. Many times we don't succeed, but the idea would be to make a step backward and to identify this patient earlier, not when they have severe symptomatic TR, but target and follow them when they are in the moderate stage without symptoms, and follow them and decide the timing. If I may, I have several questions that we can address maybe together. So one is, should pulmonary hypertension be excluded before concentrating on TR phenotype, or the two conditions should be targeted at the same time? So
why don't you answer yourself?
Yeah, so indeed, pulmonary hypertension is the issue. At first, it was an exclusion criteria until we've realized that many of these patients have HFpEF. So they may have a degree of pulmonary hypertension, and currently there is no cutoff saying above which there is ventricular or atrial. The point is the remodeling of the right chamber. So there might be patients that have significant pulmonary hypertension, but they still have a disproportionate dilation of the right atrium and the normal right ventricle. If the RV is coupled, then we can call it atrial. I'm not sure.
Very good, very good. I think we have been discussing now somehow the timing for intervention, but probably we should discuss the intervention. So why don't we go for the next presentation? We keep debating and discussing on the chat. You can also answer directly to the questions. I would like to introduce now Marianna, who is going to give us some update on what are the options for this patient. So how to deal, how to manage once we believe it's time to intervene.
Yes, thanks, Francesco. So how can we treat these patients? So first of all, let me remind, as mentioned by Denisa and as showed in her case, that before considering an intervention in a patient with atrial TR, but in general in patients with TR, we have to treat the underlying cause, the underlying mechanism. So in the case of atrial TR, we have to treat atrial fibrillation if possible, and or HFpEF with specific drugs now available. Therefore, we have to reassess TR, possibly in a euvolemic status, so a diuretic strategy, a decongestion strategy is crucial here. And if there is persistence of a significant TR, we can consider the transcatheter or surgical intervention. This is the algorithm reported in the 2021 valvular heart disease guidelines that distinguish between left side, between TR associated with the left side valvular heart disease and TR not associated with a left-sided valvular heart disease. Will focus on the latter, specifically on secondary TR. So the indication here is for patients symptomatic and or with the right ventricular dilatation, without severe right ventricular and or left ventricular dysfunction, and without severe pulmonary hypertension. And the choice between transcatheter and surgical therapy is made by the heart team, with an indication to AB for surgery based on large registries, and an indication 2B level of evidence C for transcatheter approach, because at that time we didn't have strong evidence supporting this approach. But how does the heart team choose between surgery and transcatheter? So if we look at the surgical data for isolated tricuspid regurgitation, as you know, the in-hospital mortality is high, around 9%, despite the increase in the procedure during the last decades. But probably these patients, as already mentioned earlier, come to our attention too late. And indeed, if we look at these more recent data on surgery for isolated tricuspid regurgitation coming from a single high volume center, you can see that in patients at earlier stage of disease, survival rate is 100%, whereas in intermediate and later stage, survival is lower. So how to, choose between transcatheter and surgery? We have different scores. This is just an example. The Tri-score. We also have the STS, which is now adapted to isolated tricuspid regurgitation. But I think that the Tri-score is really useful because it includes all variables specific for TR and right-sided heart failure. And this is can also be considered as a surrogate of the stage of disease. And the Tri-score more than 4 is associated, as you can see, with an increased, with a high risk of surgery for isolated tricuspid regurgitation. And this is a really nice figure showing and remarking the importance of the stage of disease in these patients. So again, surgery can be adopted at the earlier stage because the outcome is really good at this stage. At the intermediate and late stage, percutaneous approach is probably the best option with different devices according to the stage. So I generally use repair in the intermediate or early intermediate phase. I can use replacement in the more advanced phase with the heterotopic devices that need to be reserved to very late stage of disease. And this is another nice figure from the Denisa's paper summarizing all the transcatheter options for atrial TR. So you can see on the left the edge-to-edge approach and the annuloplasty for repair, and on the right replacement with orthotopic or heterotopic device. All these approaches can be used again according to the stage of disease as shown in the previous slide, but also according to the anatomy of the valve as remarked in this figure. This is an interesting sub-analysis of the tri-valve registry, including patients undergoing transcatheter treatment of the tricuspid valve, whereas you can see patients with atrial TR have a better prognosis as compared to patients with ventricular TR. Now, we don't have a control group here, but we can speculate that these patients with an atriogenic TR are those responding better to treatment. And if we look at the Triluminate pivotal trial comparing TriClip versus medical therapy, as you can see here in the baseline characteristics, most of the risk factors for atrial TR are present here. So most of the patients were females with atrial fibrillation, with a normal ejection fraction, with hypertension, dilated tricuspid valve annulus, and so on. So probably most of these patients had atrial TR. And all we know the results of the Triluminate pivotal trial showing a significant benefit with the TriClip in terms of quality of life without differences in terms of mortality and heart failure hospitalization, because probably, again, these patients are not hospitalized and don't die for tricuspid regurgitation, at least at early or mid-term, but they are treated with oral diuretics, but their quality of life is extremely compromised. And let me finish with another clinical case. Again, as you can note, it's not the same patient from Denise, it's another one, but the characteristics are very similar. So an 80-year-old female, obese, hypertensive, permanent atrial fibrillation with a previous attempt to restore the sinus rhythm without success. She complained about fatigue, dyspepsia, and the quality of life was compromised with the need for 100 milligrams per day of furosemide, low levels of NT-proBNP, so she didn't have FPEF, but she had CKD. A severe massive tricuspid regurgitation, an atrial one with a huge atria, normal right ventricular function. She had a tri-score of 5 points, so 14% of mortality after an hypothetical surgery, intermediate stage of disease. So a good candidate for a percutaneous approach, a good anatomy. The leaflets were well represented with a no too large jet. So we decided to adopt an edge-to-edge approach. So we implanted two clips, one between the anterior and posterior leaflet, and one between the septal and the anterior leaflet, and the other one between the septal and the posterior leaflet, with a good result in the huge improvement in quality of life of this patient. So in conclusion, these are my take-home messages. Patients with atrial TR, in patients with atrial TR, treatment of atrial fibrillation and or FPEF is crucial before transcatheter or surgical intervention. The choice between medical therapy, surgery, and percutaneous approach is based on the risk, the calculated risk, but also on the stage of disease. Surgery can be considered in case of early stages with low tri-score, for example. Different percutaneous devices can be used according to the stage of disease and the anatomy of the tricuspid valve apparatus. Thank you for your attention.
Thank you, Marianna. As usual, comprehensive, very clear. I want to just ask already the first question very directly. You mentioned the outcome of atriogenic TR is better than the form which is more ventricular. Is it, in your opinion, more because the outcome of the procedure is, from a hemodynamic standpoint, more reproducible for atriogenic, or it is because of the ventricle? What is your opinion? We don't know yet, but your feeling as a heart failure specialist.
My feeling is that these are patients without right ventricular dysfunction, without left ventricular dysfunction. So these are patients with a good prognosis as compared to the ventricular patients, of course. And this is probably why we are able to treat better this kind of valve, because as you mentioned before, we don't see, it's difficult to see patients with a torrential TR in this setting. So we often see these patients at the intermediate stage, so we are able to treat them better. And also they often don't have severe pulmonary hypertension. Even patients with FPEF can have pulmonary hypertension, but they don't have a precapillary component. They don't have a very high level of pulmonary hypertension. So this is another good prognostic factor.
So let me switch again from you to Denisa, because I have one question which is, in my opinion, important. We talk about atriogenic TR, but honestly, patients with atrial secondary regurgitation, usually they have a combined mitral and tricuspid regurgitation. And sometimes it's difficult to decide which valve to be treated first. And I would love to hear from you what would be the best way to decide whether we should go staged or do all together. If you go for surgery, obviously you can treat both patients together, both valves together. What is your opinion about combination of these two, and how often you see important combination of MR and TR?
Yeah, thank you. This is an excellent question. Usually in atrial secondary TR, we have less important mitral regurgitation usually. So the most important clinical picture is dominated by the tricuspid regurgitation and non-mitral. Depends on the mechanism and what has brought to the TR. If the mitral regurgitation is significant and it is likely that the TR is ventricular, so a secondary consequence of the mitral regurgitation, it makes sense to have a stage approach and wait to see maybe if the tricuspid regurgitation will improve or at least will be more feasible after treating the mitral regurgitation. But if the phenotype is atrial, so dilation of both atria, and usually these evolve together. So theoretically, they should be treated simultaneously, but we don't have strong data to support that. This is more in theoretic.
Excellent. I think we have been discussing a lot about atrial. There is a lot to be learned more. But I would like now to switch to the next topic, which is also very important, is another topic which is in the border zone between structural interventions and electrophysiology. And the topic is about tricuspid disease in patients with CIED, with cardiac implantable electronic devices. There have been an excellent, again, effort from Martin and Andreas to put together a paper which is really omnicomprehensive. And so I look forward for this presentation. Martin, you have been really good in getting information from a large multidisciplinary team. And now we know more how to do. Please let us know what you found.
Thank you, Francesco. So we published a paper this beginning of this year as part of the tricuspid focus group discussing patients who have a tricuspid valve disease and present cardiac implantable electronic devices. These are my disclosures. So we do have about 3.8 implantations of pacemaker per million inhabitants in Europe, 2.2 ICDs and 1.8 CRTs. And this is quite a number. And we have to know that about up to 30% of those patients do have a lead-associated TR, which means that there is no real connection between the leaflet and the lead, but there is a tricuspid regurg present and a lead through the tricuspid valve. And up to 5% do have a lead-related TR, which means that the lead is somewhat involved in the development or persistence of the tricuspid regurgitation. There are several studies showing different numbers of tricuspid regurgitation, but it's about 30% in most of them. There are different risk factors associated with the development of tricuspid regurg, which is, for example, the number of leads involved, consequent or 100% apical pacing of the right ventricle, the angle the lead is implanted, or pre-existed dilation of the right ventricle. And there are some mechanisms which are involved in the development of tricuspid regurgitation. Some of them are related to the implantation procedure. For example, entanglement of the lead in the subvalvular apparatus or perforation of the lead through the valvular tissue, or leaflet impingement or adhesions to the lead. Then there are pacing-related regurgitation if the right ventricle remodels due to a significant amount of pacing. And we do have device-related mechanisms like endocarditis, extraction, or fibrosis. Most importantly, and this is another report published by Becky Hahn in the Czech this year, that we can diagnose these relationships between the lead and the tricuspid valve with 3D echocardiography, and there are the new devices are really good in finding the mechanisms. But also, if we still have questions or we plan a procedure, 3D or 4D CT helps us to understand the mechanism and visualize the lead going through the valve. If we have a lead-related tricuspid regurg, this is on the left side, we have to decide if we can operate those patients. Low-risk patients, young patients should still undergo operation, or if we have to do an intervention in high-risk patients. And then we can decide if we replace the valve or repair the valve. But if the tricuspid regurg is associated with the lead or related to the lead, we have to think about lead extraction also, if lead extraction plays a role in this case. And this may also be relevant, especially in patients who have the lead not implanted too long ago, so where there are no strong adhesions. If we go for surgery in those low-risk patients, we can replace or repair the valve. We have to really assess the risk prior to surgery, and we have to think about lead extraction in combination and place epicardial leads. We nowadays have the opportunity to use total endoscopic surgery also in redo cases to really bring down the risk of the procedure and enhance post-surgical recovery. This is a case I operated on 10 years ago where we had no option for interventional treatment at our department. And you see that there's a severe tricuspid regurg related to a whipping movement of the pacemaker lead. And what we found during beating heart open surgery is that the lead was screwed into the papillary muscle. So a clear mechanism here, and surgery was able to get this patient back home, and we also placed epicardial leads. The data now for isolated tricuspid regurg are better than 10 years ago, and this is basically in addition to improved risk assessment due to better inotropic support and due to some methods like ECMO or temporary air valve we can use to get patients over the critical post-operative phase in the left ventricle. We also have to think about the coupling. We've heard about it today. Patients who have a high pulmonary pressure and a low right ventricular function are at highest risk for those procedures. And then if we go for surgery or intervention, we should include also electrophysiologists and discuss the risk of lead extraction to improve outcome. Options to treat the tricuspid valve with leads in place are obviously the TEER procedure with the TriClip or the Pascal system, and this is the placement is typically in a so-called Clover technique to repair the valve. And we know from our registries that the outcome is pretty comparable if there is a lead in place or not. But nowadays, we also have the option to use the Evoke valve or other study valves to replace the valve if the gap is too big. And there are also published data that leads can be left in place, but they also can be extracted. And this is still a hot topic. If there is no option for replacement, there are some extra anatomic options, like, for example, the trick valve, which is a valve in the superior and inferior vena cava. And data show that patients have improved quality of life in these no-option patients, and also that the volumes of the atria is reduced after trick valve implantation. So in conclusion, we have to account that probably it's best to do an echo prior to and after pacemaker implantation to see if there's any change to the tricuspid valve. If we do have an increase of tricuspid regurgitation early after pacemaker implantation, simple extraction or explantation of the lead will resolve. Late stage extraction may not be as beneficial. Surgery is well established and should be done in specialized centers to protect the right ventricle. And transcatheter options are rapidly evolving and should also be applied to patients who have a higher risk. Thank you.
Okay. Martin, really monumental work. Thanks so much for what you have done.
Yeah.
I want to ask Denisa if there are some reactions from the chat. Denisa, you have been seeing something?
Yes, we have a very interesting question. What is the relationship between HFpEF and TR, and whether HFpEF is a contraindication for treating TR?
So first of all, I'd like to then involve Marianna with two heads, the head of the interventionist and the head of the heart failure specialist. It's a specific question. So is it a contraindication?
No, it's not a contraindication. It's a typical overlapping phenotype as shown by Denisa. It can, of course, leads to pulmonary hypertension and right ventricular overload, NTR, or it can be associated with an atrial disease involving especially the right ventricle. We don't know the mechanism why this happens, but the right ventricle is often more dilated than the left one, and also it is a condition often associated with atrial fibrillation. So the combination of the two conditions, atrial fibrillation and HFpEF, can lead to TR, and this is not a contraindication. This can be, but this is just a feeling, we don't have evidence, a reason for persisting symptoms after the treatment. But we know that nowadays we have also good medical therapy for treating FPEF. So the combination of devices and medical therapy will, of course, work in these patients.
Very good. And I want to go back to the topic from Martin, because I am really impressed by this publication. I want to ask you, Martin, you have been busy building this paper together with electrophysiologists, and I think we are actually opening a new door of collaboration. And I think the awareness about the TR management or tricuspid valve management around the CIED implantations is growing. So do you see a growing need for more collaboration between surgeons, heart failure specialists, interventionists, and electrophysiologists? What happens in your practice?
Yeah, definitely. You are completely right. I think we really should increase the collaboration, also include electrophysiologists in the routine heart team process if the tricuspid valve is involved. I think there are several strategies to improve outcome of those patients, because some of those patients who receive a pacemaker early in their life need probably new leads, will probably need some interventions, and they also need to consider some lifetime management. So I think there's a lot to be discussed and a lot to do. And I think we also should really think about improving echocardiography prior to and after pacemaker implantation, because this is something which is not regularly done widespread in Europe, and this would improve outcome on the long run for these patients.
So again, from a surgical perspective, you have shown the different options. You also showed us a common trend today of jailing the pacemaker wires, the pacemaker leads, in patients who undergo structural interventions. To be honest, happens also, I think, in surgery. What is your practice? Do you think jailing a lead is something which is acceptable? Is it's a compromise? I've seen even in surgery, some surgeons are jailing the leads when they do valve replacement, for instance. What is your practice?
Personally, if I have a surgery, I prefer to remove the lead and place an epicardial lead to have the valve free. If I have to implant the pacemaker after valve repair or replacement, I rather place it in the left, in the coronary sinus, to avoid the valve totally. And if there is, if the surgery is over, I tend to, if the pacemaker is needed thereafter, we prefer to do coronary sinus. And in TEER procedure, I still do jailing, because sometimes you don't have to jail it. You just have to push it away.
Okay, but then this is the best way to move forward and give the word to a real expert in lead management, I would say, an expert in extraction, but also an expert on implantation, Christoph Stark from Berlin, really a very experienced surgeon, one of the most experienced in Europe. So, Christoph, what can be done? What is the technology that we have to manage these leads? And from your perspective, what is the best approach to this field?
Well, thank you, Francesco, for your kind introduction. It's my pleasure to be here. And well, I want to talk a little bit about lead management and the techniques for lead extraction, how it affects tricuspid valve. So these are my disclosures. And I want to go back what Martin said. I mean, there's lead associated and lead related TR, and especially in patients with lead related TR, where you do have some interaction of the lead with the tricuspid valve, it seems compelling that doing lead extraction, taking out the lead, will help somehow. But we really have to look into this. Does it really help? Is it valid, or is it just a myth? And if you look into this study, more than 300 patients, where they looked into TR pre-extraction and post-extraction, you can see there is some dynamic, okay? If you look into this graph, so you see arrows back and forth, you see improvement, but you also see worsening. But to be honest, this picture is just not relevant change. And if you look into the relevant changes, then you see that this is really just a myth, okay? So making TR better, but just by extracting a lead, works only in very few cases. And on the other hand, you can also see you can make it worse, okay? And you also see that on the left side. So whenever you do lead extraction, you have to be aware you can make it worse by doing this, especially in long implanted leads. So it is a myth that you can improve TR significantly by doing lead extraction. And then if you think about lead extraction and how does it, what is the impact of lead extraction on TR, especially in patients where you make it worse? You can see there are some technical aspects. So using powered sheaths, here you can see a laser sheath is a risk factor to make TR worse after lead extraction. And then also, and this is probably one important thing, the longer the lead implant duration is, the higher is the risk for significant TR after lead extraction. So this is also a risk factor here. Well, but as we said, we know that during implantation, there are some critical sites where there can be interaction between a lead and the tricuspid valve. So, me just saying it's a myth that you can make it better, is it really true? And if you look into this data, where they had a look into also TR after pre and after extraction with regard to the position of the lead, you can see there is some dynamic here in contrast to the results of the other study. But to be honest, this is a small number study, and also lead implant duration was quite low here. So the key fact, if you really want to talk about does lead extraction or lead removal help, is implant duration. So then if we talk about lead extraction and techniques, we know we have different tools today to do lead extraction, and we have basic principles to adhere to make it safe. And one basic principle is the rail effect. So use the lead as a rail to guide your sheath to extract your lead. And this rail effect is really important to minimize complications, not only vascular complications, but also damage to the tricuspid valve. Another technical aspect in lead extraction procedures is the so-called tandem approach. This is actually, in my opinion, a quite new approach, how you can avoid damage to the tricuspid valve if you're worried about this during an extraction. And what you do in a tandem approach is you grab the lead from below with a snare and you fix the lead in the right atrium, so that when you use your extraction sheath, you're not transmitting any traction forces onto the tricuspid valve, and that avoids, obviously, tricuspid valve damage. Yes, at some point of time, you will have to advance the sheath over the tricuspid valve, and here you have to be careful that you don't damage anything. So then Martin already touched the topic of alternative ways to implant devices in order to avoid interaction with the tricuspid valve. Epicardial leads for surgeons is clear, but also CS leads were touched. But then we have leadless pacemakers nowadays, which at least, and you can see this on the right-hand side, show initial promising results with regard to their effect on the tricuspid valve. So meaning that you don't see any significant worsening of tricuspid regurgitation after implanting leadless pacing devices. And then also, if you think about ICDs, think about subcutaneous ICD and the extravascular ICD. So now I want to touch two more clinical scenarios with regard to leads and the tricuspid valve, which I think are important. First of all, it's tricuspid valve endocarditis and patients with devices. And here, in most cases, to be honest, this is a surgical case. So you will have to do surgery for tricuspid valve endocarditis. And while doing this, of course, take care of the device and the leads. In some select patients where surgery is not an option nowadays, you can do in the setting a transvenous lead extraction and percutaneous aspiration of lead vegetations using, for example, the AngioVac system. The second clinical scenario I want to touch is patients with lead failure of right ventricular leads. So what do we do in this scenario? Is this a scenario where we go for lead extraction, or do we just add leads? And to be honest, Martin also told us already that the number of leads is a risk factor for TR. And just adding leads, at least in younger patients, in my opinion, is not an option. You should certainly avoid situations like this, which is a complete lead cemetery, and having so many leads across the tricuspid valve, that's just horrible. So as said before, lifetime management of these patients is really important, and especially in young patients, if they come with lead failure of a right ventricular lead, you should extract that lead. So, and at the end of my talk, I want to show you a short clinical case. A 78-year-old female patient got a dual chamber pacemaker, got a dislocation of her right atrial lead. And at the external hospital, they wanted to do a revision of the right atrial lead. And when they started, pulling on the lead, they felt some resistance. So they were clever. They sent the patient to our center, and we took took care of the patient. So this was the starting chest X-ray and the starting situation. You can see the right atrial is not where it's supposed. Right atrial lead is not where it's supposed to be. It's radiologically already somewhere in the context of the tricuspid valve. And then here you see we start the procedure. We start pulling on the right atrial lead, and there is resistance, and the resistance becomes clear when we looked at the echo pictures. So the lead was entangled in the subvalvular apparatus of the tricuspid valve. So it was clear if we just pull on this lead, there was a high risk for damage of the tricuspid valve. So we voted to protect the tricuspid valve during this procedure by the tandem approach. As I showed you before, using the tandem approach, you will secure the lead, and you will make sure that the traction forces will not result in damage of the tricuspid valve. And as you can see here, so we came from below with the needle-eyed snare and grabbed the lead from below to fix it. And then we used a extraction sheath to carefully release the right atrial lead from the tricuspid valve, which was done successfully. And as you can see in the echo, there was no damage to the tricuspid valve. So this was really, really helpful technique in this patient. So at the end of my talk, I want to just give you one take-home message from my side. With regard to TR and device patients, this is really something that should be a multidisciplinary approach, and the device specialist has to be an integral part in this team. Thank you very much. Back to you, Francesco.
Thank you, Christophe. Fantastic case presentation on this almost big failure that you managed as a success. I think I have a lot of questions, and I want to use this opportunity to ask you the same question I said before. There is the possibility of jailing wires, jailing leads. Today, patients with leads are very commonly referred to us. They have severe TR, and in some occasions, these patients, and particularly in the future, these patients will be considered for transcatheter tricuspid replacement. And this will be done often jailing the lead. Did you ever encounter a patient where you had to remove the lead, extract a lead after transcatheter TTVR?
Yes, I did, and obviously it's possible. But to be honest, you know, the question in the first place is, should we jail leads? And you know, asking me as a lead extractor, I would strongly suggest not to jail leads, even though I'm aware there are initial data of you know, jailing leads with transcatheter therapies and having good initial results. But to be honest, this is something which we have to look at in the intermediate stage and the long term. And you know, one important aspect is we're talking about, you know, potentially destroying the function of a lead. And in a patient that's pacing dependent, that might be, you know, a real big problem. Because I mean, if your life depends on your right ventricular lead, and this is gone somehow after you jail the lead, then this might become a problem. And especially if it's in the, you know, in the longer term run, you know, you send the patient home because everything looks fine in the beginning, and all of a sudden the patient is at home and the right ventricular lead stops functioning. That's a big, huge problem.
That is absolutely an important point, again, that underlines the value of debating and exchanging ideas in this field. I can say the same about, you know, east bundle pacing is a pain in the neck if I need to do a transcatheter repair, because is going to be exactly in front of the anteroseptal line of coaptation. So there are so many features and so many border zones where we should really build a new practice altogether, understanding what is the best option. And future will tell us, for instance, if will become standard practice to extract the lead, implant the valve, and then implant another, maybe a leadless pacemaker or a pacemaker lead in the coronary sinus. Okay, before we close, I would like to know from Denisa if there is any burning question from the audience.
Yeah, we can take a very quick one. If there is any protocol for echo assessment pre and post implant, and how to do the surveillance after implantation.
That's a very important question, and I want to ask you if there is, obviously, and what is the adherence to this practice?
Well,
yeah, that it.
Okay, both. For first, Christophe, from your side.
Okay, so first of all, the one and easy thing is have a look at the tricuspid valve. Has there been tricuspid regurg before, and is there tricuspid regurg after? It's as easy as this. And if there is relevant tricuspid regurg after implanting a lead, go back in there and take care of that lead, you know, because it will not get better. It will get worse, and we will have all the problems that we just mentioned today. So just have a look at TR.
And so, Denisa, let's imagine the patient comes back to you, and there is a patient who has mild to moderate TR, which was not there prior to the lead implantation. So, in theory, this patient is a patient who can tolerate TR. But so, what you do after that? Will you follow the patient strictly? Because we understood that in case you need to reposition or to extract the lead, time matters.
I will try first to define the mechanism. If I have a TR that is eccentric, then I would do a 3D echo to understand whether there is impingement on the leaflet. If it's a central jet and I have an explanation for that TR, I will try to manage it like a ventricular TR or an atrial TR. But if I have a suspicion that there is related to the pacemaker, I will try to demonstrate that and to address it. And if needed, if it's early, then I will try to consult the electrophysiologist and maybe reposition already, because, you know, if it's mild to moderate, it's probably moderate or more. We always underestimate the severity.
Thank you very much, Denisa. And unfortunately, we are at the end of this webinar, which has been full of information. We learned a lot. The first half of the webinar has been dedicated to atrial secondary TR, which is now a well-established phenotype with predominant dilation of the right atrium and tricuspid annulus. And we understand that these patients, mainly because of the lack of right ventricular failure, they have a better outcome, a better prognosis. But obviously, there are still patients who may benefit from this, from therapies, starting from rhythm management and going towards more structural interventions. We learned from you, Denisa. We saw a nice case presentation showing that prior to structural interventions, there are many other options, and particularly in heterogenic TR, think about rhythm management. And that means that you know, we need to work in a group. Working in a group means we have all the experts around these patients. We can have multiple options and find the best option for these patients who need a comprehensive and multi-parametric evaluation to find the best option for each individual patient, because below the level of the first stratification between atrial and ventricular, we know there are many other subcategories. Another very important and really exciting field for innovation, and in my opinion, even for expanding our teams, is the management of TR in patients with CIED. And first, probably the key message, and I hope this will become standard, hopefully in every case, TR, tricuspid valve function, need to be assessed prior to and after any CIED implantation. It is very important because there are solutions which are simple prior to have a CIED-related tricuspid valve disease, which is a very complex scenario. We have learned how many questions are still open, requiring a multidisciplinary approach. This, I think, has been achieved till now by the tricuspid focus group, involving and including multiple professionals around patients with tricuspid regurgitation. With this, I'd like to really thank everybody for the contribution, and thank all the audience to be participating. And I look forward for more from Tricuspid Focus Group. Thank you very much.
All right.